WCCF News Radio 1580.
Good morning and welcome to the Slippery Slope of Lipids and Other Medical Issues, brought to you by the Triana Prevention Center in Port Charlotte, Florida. This is a live medical talk show in which you're invited to participate. If you have a question or comment along the way, please call us at area code 941-206-1580 or toll free at 888-441-1580. You can also follow along at WCCFAM.com. Click the link on the homepage to view our webcam. And now, ladies and gentlemen, your host of the show, Dr. Elizabeth Triana.
Good morning, everyone. Boy, we have a great guest today. But first, before I introduce our guest, this is Dr. Elizabeth Triana. I want to thank our guest last week, Sherry Carr from the Y. Boy, she's so energetic, getting us to exercise. I'm thinking about doing it myself. No, I think it's very important. And she was great, and Dr. Katzen giving us our imaging minute. But today I want to present to you the most loveliest lady, such a wonderful doctor, Dr. Vance Brownie from Florida Cancer Specialist. Welcome, Dr. Brownie.
Thank you, Dr. Triana.
I am so happy. I've known Dr. Brownie for a long time, and I'm going to tell you, your patients adore you.
Thank you.
It is. So Dr. Brownie is a hematologist-oncologist. Talk to us about what is a hematologist-oncologist?
Well, that's a good place to start. A hematologist is a doctor who looks after blood problems, as opposed to an oncologist, who's a doctor who looks at cancer problems. Both of those are often paired, and so in a fellowship, we'll often do both.
Very good. So blood problems, because I know I've sent you patients, and they see on the wall the marquee says Florida Cancer Specialist, but they need to know that many times if they have a blood problem, they will be going there also to see you for that reason.
And that's one of the first things I tell patients as I walk in the room. Hi, I'm Dr. Brownie, but you're here for your blood. You don't have cancer. It's not that someone didn't tell you. And
Correct.
Here you are. So it's important to reassure the hematology patients that, yes, they in fact don't have the dreaded C word, as I call it.
Yes. And yet, even if they do, let me tell you, I'll go there in a minute, but you're so calm and reassuring that no matter what the diagnosis is, you handle it so well, and I know that you help patients so much. So what gave you? And one of the reasons I like doing this program is because I want my audience to know that we as doctors are humans, and sometimes people don't have a good opinion of doctors, and I'm working to change that. And I want to know from you, what was the passion? Tell me. That led you in the direction to become a physician?
As far back as I can think, I really liked helping people. And that may sound a little corny or a little cliche, but it really is the core reason for why I do what I do. And to sidetrack a little bit, for example, I tried doing pathology and just didn't like it. I love the human contact, I love the live contact, I love being able to help someone, and I tell my children there's no better job than for you to make a difference in someone's life.
Of course, always. I know as a physician, and you're there not only to make a difference, but to help them to live longer.
Live longer and live better.
Right. And that's so important. So what led you to be your specialty of oncology?
A little bit of a bleeding heart.
Bleeding heart?
For me, it's never enough to just say I can't do anything. And I think the first time I thought about oncology was actually when I was in medical school.
Mm-hmm.
My physiology book said that the average survival of a child with leukemia in 1954 was 6 weeks. And I thought, 6 weeks?
Oh.
that's impossible. And how do you as a parent deal with that kind of news? And that was in the 1970s when I was 80s in medical school. And at that time, we were curing about 70% of leukemias and childhood leukemias. And so one of the things that struck me was between 1954 and 1980, you'd gone from 6 weeks to a 70% cure rate. And that was, to me, amazing.
That is amazing.
And if people in 1954 had not said, this isn't good enough, if doctors hadn't said, this is not acceptable, to just say, oh, well, you've got cancer and there's nothing we can do about it, then we'd never be at 70% in the 1980s, and we wouldn't be at 90%, which is where we are today.
Amazing.
Understand that chemotherapy is relatively new. There was no chemotherapy before the 1960s. And so there's been a tremendous development of things we can do for cancer. We're not there yet in terms of curing everyone, but the number of things we can do has grown exponentially. And I really believe if you don't try, you'll never get better. So if we don't try to keep treating cancer, if we don't try to keep pushing the envelope, learning more, developing more treatments, we're never going to get to the ultimate goal.
I think that's a great, that's a great attitude.
Thank you.
To have. Because people, a lot of times, again, they hear the word cancer and then they just say, I'm not going to do anything.
Right. And I think that's fair. It is a very scary word. And I will use the word cancer in the office not to scare people, but for them to become used to the idea that it's a word just like any other word, and that we have to deal with it, get used to saying it, and figure out what can we do next. I'll often tell patients, don't look all the way down the road. Just ask yourself, what is my next step? What do I have to do as the next thing to tackling this? Because if you look all the way down the road, you may feel overwhelmed.
How do you explain the word cancer to a person who has no medical background?
Cancer is a cell that grows too much. It's uncontrolled growth. So normal cells grow, but when they touch their neighbor, they stop growing. And they stay where they're supposed to. So a kidney cell stays in the kidney.
Right.
Cancer cells don't have those boundaries. A kidney cancer will not only grow, it will strangle its neighbor, it will take over the blood supply of the kidney, it will go through the bloodstream to other organs, and grow there till they collapse. And so it's a cell that doesn't know when to stop growing, is able to travel, and is able to take over other organs. And that's really how cancer kills you. It causes your organs to fail.
Okay.
And that's why cancer is often found late, because it really is pretty silent until it makes something else stop working. And that's how patients come in. It makes your bones break, so you hurt, so you go to the doctor.
Or maybe they feel a lump.
Exactly.
Like in the breast. Or I had a patient who, in my office, appeared to be having a stroke,
Mm-hmm.
and instead had a brain tumor, glioblastoma.
Right.
And it was not that. And the patient was doing great all the time, and all of a sudden, like that.
And again, it's because it affects the function of an organ. So that's how you come to medical attention.
And part of treating is to target that cell that's going berserk.
Correct. One of the things that's not widely understood is that when cancer spreads, it's the same cancer. So I will have patients say to me, well, my uncle had lung cancer, and then he got bone cancer and brain cancer. And I often have to say, well, it's still lung cancer. It just travels somewhere else. And the way we treat, or the way we choose treatments, is based on where the cancer began, which is why the biopsies are so important, and accurate information from your biopsy is crucial to helping your cancer doctor choose the right combination of treatment.
Correct. And if anybody has any questions, please give us a call at 206-1580. We have Dr. Vance Brownie from Florida Cancer Specialist. We're really lucky to have her today. She's a very busy lady, and it's great. Or if you want to call us at 888-441-1580. It's really, I'm really happy that you're here, Dr. Brownie, and helping us to understand this because I think the biggest question is fear. And one of the questions I get from patients is, for example, and we'll talk more about breast, is I don't want to get a mammogram. I'm not going to do anything about it.
Right. And I think fear is the major driver of that. Perhaps if I ignore it, it will go away. I will tell patients mammograms don't cause cancer. They just pick it up early so that we can do something about it. And one of the most important things is stage. The earlier you find a cancer, the higher your chances of cure. And so a stage 1 breast cancer, generally speaking, is curable. And by curable, I mean going away and never coming back about 80% of the time.
That's very high.
That's a pretty good odds. On the other hand, if you have a stage 4 breast cancer, your chances of being cured are less than 5%. So while you may live a long time, and breast cancer is one of those diseases that even when it's spread, you can live for a long time, my chances of hitting the ball out of the park, of curing it, are directly related to how early we find the disease.
And as a hematologist oncologist, you also deal with blood cancers. I know a very famous person, I think Tom Brokaw, was just diagnosed with multiple myeloma. So, of course, that goes all over the news.
Right. And his case demonstrates, again, the advances we've made. When I was a fellow, 10 years ago, but really about 19 years ago, there were 3 or 4 drugs that were effective in multiple myeloma. Now I can list you 10 without even blinking an eyelid. So the number of drugs and the number of choices that we have has increased in multiple myeloma as it has in a lot of other cancers. Multiple myeloma, my oldest patient that I've treated was 92 years old.
Wow.
She was treated with an oral regimen, and she did well for a time. Ultimately she succumbed to her disease, but she was able to be treated and effectively treated and remain in her home in the community, not in the hospital.
One of the things I always say on my show is more good years. At the Triana Prevention Center, we want to have more good years. And the other night, I went to a show, and it was an Elvis Presley impersonator. They had 2 women in the show, not in the show, but at watching the show, who were in their 90s. Mm-hmm. And they were dancing and happy, and they went up and kissed the Elvis impersonator. I mean, so when someone says, I'm 75, I'm 80, well, look, there's people in their 90s, like you said, your oldest patient. Mm-hmm. And it's so much wonderful that they have more good years, and they can still live with these diagnoses.
Correct. I think the issue is how functional are you? And if you're functional, enjoying life, able to do for yourself, be for yourself, and be who you want to be, what's the point in stopping?
Of course, and I agree. And that's why we want to try to catch things earlier. So talk to me, what's the number 1 cancer killer in women?
Actually, it's lung cancer. A lot of women would believe that it is breast cancer, but lung cancer is the primary cause of cancer deaths in women in the United States. And that's a residue of our emancipation when we began to smoke in the 1960s and 70s. And unfortunately, we're paying the price for that. So for any smokers out there, the best thing you can do for your health is to quit smoking. The second best thing is regular exercise.
It is. It's true. And it's for your vascular health, too.
Absolutely.
Because it causes inflammation in your arteries. And I explain to people, too, also, it causes COPD, chronic diseases. I explain to people it's like getting a burn. You're burning the inside of your lungs. So that's one of the causes of the lung cancer, the changes.
Correct. And we often focus on lung cancer, but smoking also increases your risk of head and neck cancer, pancreas, stomach, bladder, kidney, as well as lung. So it's not just lung. We focus on that because it's the most common.
Right.
But it increases your risk of multiple cancers.
So there's a new guideline out there. Talk to me about the new screening guideline.
Right. Probably the most exciting news in lung cancer, in my opinion, for years in lung cancer screening. We have done chest x-rays in the past, but without any real evidence that they help to decrease mortality from lung cancer. So you'll have a patient say, well, my lung cancer was found on a chest x-ray, and that may well be a valid point. But the goal of a screening test is that if you do the test on somebody who has no symptoms, you can prove that you improve cure rates. That's the definition of a screening test. You have to do the test on somebody who doesn't have any symptoms and show that you pick up the cancer early enough to improve cure rates. And that happened for the first time in lung cancer with a test that's called a single breath hold screening CT. This test, when administered to a target group of lung cancer, of smokers, showed a reduction in your chances of dying from lung cancer of 20%.
That's very high.
And that was a yearly CT chest low dose. The low dose is because the risk of the radiation exposure is minimal with a low dose chest CT. And it showed a positive result in in 2 large randomized trials. Therefore, the recommendation now is that if you have over 30 pack years, and the way you calculate that is number of packs a day times number of years smoked. So if you smoke 2 packs a day for 15 years, that's a 30 pack year history. If you smoked a pack a day for 30 years, that's a 30 pack year history. So if you have more than 30 pack years and you are a current smoker or have quit but under 15 years duration,
right,
you are appropriate for screening. So I want to make it clear, not everyone is appropriate for screening, but that group of patients with a yearly chest CT, we can reduce the risk of dying from lung cancer.
That's really excellent. And unfortunately, not all insurances will cover it at this time.
Correct, but I think it's important to, 1, get the word out there, 2, make the case that it's always easier to treat and cure than it is to treat late-stage disease. And I would also say that the United States Preventive Services Task Force has now recommended this test as an appropriate screening intervention for the right patients.
Well, I've been practicing for a long time, and I actually remember when mammograms were not covered by insurances.
Correct. And we can argue about how frequently we should have mammograms or when they should start, but the take-home message remains the same. Nobody can argue with the fact that mammograms given in a consistent fashion reduce your risk of dying from breast cancer. And that's the bottom line.
I know there was a Canadian study that came out. However, they were trying to cut back in the amount of mammograms. But then again, the equipment wasn't up to par. The readers weren't up to par. So there was a lot of holes in that study.
As I said, there are a lot of studies. I have not seen a study that definitively debunks the fact that mammograms save lives. So you can argue about every year, every other year, when you should start, when you should stop. But the preponderance of the data points to mammograms reducing your risk of dying from breast cancer when given in a regular and consistent fashion.
So I have some patients who are older and they said, well, I read that I don't need mammograms anymore. And I've even had patients who were in their 60s tell me that. And I said, no. So talk to me about that.
I think guidelines are just that. They're guidelines. And so the way I look at it with my patients is how functional are they? How well do I think they're doing? I have one patient who was 92, and we kept doing her mammograms. Why? Because she could walk 5 miles every morning around Southport where she lived. She had no other health problems. And so the question you ask is, if I do the mammogram and I find a lump, is she appropriate for surgery? And if the answer is yes, then I think that patient should be screened as long as they are interested in having something done. I have stopped doing mammograms on patients who are younger than age 70. I have one patient who had a major stroke, and she was still able to communicate with her husband. She had had past breast cancer, and they decided that even if she found something, she wouldn't want anything more done. Therefore, one should stop looking. So it really depends on how well is a patient, and do they want to have anything done, and are they in the kind of shape where if you found something, you would do something about it. If they are, then I still recommend screening mammograms.
And again, I think the take-home message is that it's a personalized. I believe in personalized healthcare. It's to, like you said, the lady with her husband, her past history, family history. We take that all into account with her physician, who was you, makes a decision on what is the next step or what, to do more testing or not. So I think, again, it's not this cookie cutter medicine or this average of a graph. We are each individual. And I think that's a wonderful thing that you just give a perfect example.
And I would say never let the decision be driven by fear. Oftentimes people will avoid screening tests because they don't want to know the answer. And again, early detection is key. The earlier stage, the better the chance of cure. And that's really what the bottom line is.
I think that's great. Let's take our break.
You're listening to The Slippery Slope of Lipids and Other Medical Issues, brought to you by the Triana Prevention Center in Port Charlotte, Florida. We encourage you to visit their new website, which is trianapreventioncenter.com. That's TRIANA Prevention Center, all one word, .com. To catch up on previous shows, there's an archive going back to the beginning of this program, covering a wide variety of topics. Dr. Triana is accepting new patients currently, and we'll ask the doctor to give her phone number out in just a little bit. In the meantime, if you'd like to call this program, our numbers are 941-206-1580 and toll free at 888-441-1580. And now, back to Dr. Elizabeth Triana.
So welcome back, everyone. We are here, the slippery slope of lipids and other medical issues. We have a great guest, Dr. Wright-Browne from Florida Cancer Specialist, who is, again, I have to say this, you're so calm, you're so reassuring, and you're so great with patients. It's just wonderful the way you are, and I almost feel like either you picked your specialty, I know, but then God gave you those attributes too, so you could do what you're doing, which is a wonderful, wonderful. You've been in this community for how long?
18 years. I arrived here in July of 1996.
Oh my God!
Straight out of fellowship in Houston. And
wow. Oh, you were in Houston.
Yes, I trained at MD Anderson, and then once we were finished, we had family in Florida, so we looked to come south, and here was Punta Gorda and Port Charlotte.
That's wonderful. Boy, MD Anderson, that's a great place too.
It was a wonderful training.
What a wonderful training. The premier in the world, in the country, if not the world, for cancer treatment and training. That's fantastic. So we've been talking about lung cancer, which again, we know that the number one killer of men and women is vascular disease, heart. But the number one killer of women, cancer, is lung. How about men?
Lung also. Now, prostate cancer is the most common cancer in men, as breast cancer is the most common cancer in women. But you have to talk about what are the major causes of death.
Death. Mm-hmm. Okay. So but it's more common to get breast cancer, but you're less likely to die from it.
Correct.
Okay. And men, most likely to get prostate cancer, but less likely to die from it. But lung is the number one in both men and women. And as you said, because of smoking.
Primarily related to smoking.
Primarily.
Now, you will, again, often hear, well, people who don't smoke get lung cancer too, and that is very correct. That is true. But smoking does increase your risk, and I go back to it's likely the best health decision you can make for yourself to quit smoking.
I also see that there's an increase in my practice of older women having bladder cancer because they used to smoke.
Correct.
More and more.
And that makes the point that smoking affects not only the lung, as we talked about, but multiple other organs also.
And what other treatments any other new treatments that you were going to talk about for lung cancer?
Well, lung cancer has also undergone an explosion of treatment options. As we were sharing before the show started, when I was a fellow, there was one drug for lung cancer. And the question in patients with advanced disease was, should we even treat those patients? Because it worked so poorly. Over the last several years, we have come to recognize that there's not just one type of lung cancer, there are multiple subtypes of lung cancer. And we're now beginning to choose treatments based on the subtype and the knowledge that certain subtypes respond better to particular drugs. And so when I see a patient now with lung cancer, instead of just saying, oh, well, you have lung cancer, let's reach for this medication,
Right.
you send the tissue off for additional testing, and your choice is based on those results.
You know, they have a lot of commercials on TV. Certain cancer clinics are talking about genetics.
Right, correct.
Talk to us about that.
Okay. The tests that they're talking about are really the frontier of medicine. And what these tests try to do is identify the particular drivers in each person's cancer. So instead of just saying, oh, this is a non-small cell lung cancer, you can test the genetics of the tumor and see what makes it tick. What exact growth processes are going on in your individual cancer? And these tests are available commercially. We can get them in Port Charlotte just as well as we can get them at, the regional cancer centers that are advertising.
Okay, well, see, that's good to know.
And they are commercially available, certainly able to be sent out by pathologists and by your oncologist. And that's the information that I'm talking about that helps you to more intelligently choose what you use to treat a patient.
Like the advanced testing for breast cancer.
Correct. It's a similar principle. And the way the field of oncology is moving is precisely towards that, not only in breast cancer and lung cancer, but in all tumors, trying to test the individual tumor of that patient and figure out what makes it tick, and therefore to choose your treatments based on that. Now, understand this is in the early stages of development,
right.
So I don't want listeners to think, oh, there's a 100% chance of response if I just get this test. That's not correct. But it's the next step in trying to make a smart decision. And that's what the word targeted therapy is. When you read now about cancer, there's a lot of talk about targeted therapies. That targeting is simply trying to see what makes your tumor grow and how can we therefore choose treatments that more effectively will shrink it.
Hello, caller. You're on the air.
Well, this is your mother.
Hi, Mom.
I want to tell Dr. Brownie that it is not corny that she wanted to be a doctor very, very early, because you kept saying at 3 years old that you wanted to be a doctor. So I understand how early one can have a desire to be a doctor.
Well, Mom, thank you so much for calling.
I also have a question for Dr. Brownie.
And thank you for the comment. I appreciate it.
She speaks wonderful of you, Dr. Brownie. My brother went to see you because they thought he had a leukemia, and you did a bone marrow years ago, because my father died at A.E. Anderson of leukemia. Is leukemia hereditary, sir, ma'am? Doctor?
All right. Thank you, Mom. Can you have another question?
No, I wanted to know, because I also had an uncle that died of it.
Yes.
So is this hereditary?
Leukemia is not hereditary in the general sense, but understand there are many different kinds of leukemias. And so there are some leukemias, like chronic lymphocytic leukemia, which does seem to have ability to run in families. So the question is not one that I can either answer yes or no. There's certain subtypes of leukemia where you do seem to have a higher family risk. But generally speaking, leukemia is thought to be incidental rather than a hereditary condition.
Okay. Thank you, Mom, for calling. Okay. I think she hung up. Thank you, Mom, for calling. It's always great to have your mother as a fan, isn't it?
Mothers are always fans. That's why they're mothers. It comes with the territory.
And I know you have kids too. And you grow orchids, right?
Absolutely. Now, in season, I don't take care of them as well as, or as often as I could. But yes,
We
I
have
grow
another
orchids.
caller. Get caller?
Yes, doctor, I want to thank your mother so much about asking the question about leukemia. It's something that I have wondered about for such a long time because there is leukemia in my family.
Oh.
So I thank your mom for asking that.
Well, sweetheart, thank you so much for calling and listening to the show. Do you have any question for Dr. Brownie besides that one?
Not at the moment, no.
Well, thank you.
I just wanted to thank her because that's important for me to know that.
Well, thank you so much for listening. Thank you.
Okay, bye.
We have some wonderful audience, just a wonderful audience. I run into the community and they tell me thank you, and they're learning so much. So I thank you, Dr. Brownie, for being here today. You don't know.
It's a pleasure getting the word out about anything I can to do with oncology or blood disorders is a passion. So.
Thank you so much. Yeah, you could tell that you have this passion. So could you give us some information about preventing breast cancer? What can women do to prevent breast cancer?
That's a complicated question.
I know.
And one of the reasons it's complicated is that the studies are often contradictory. So having said that, here's what has stood the test of time, if you would. A prolonged period of menstruation does seem to increase your risk of breast cancer. So if you have your period early or if you had menopause late, you are at increased risk. Steady, consistent intake of alcohol, more than 2 drinks a day, for reasons we don't understand, seems to increase your risk of breast cancer occurrence. So that's something that's not widely known and that I do caution patients about.
Yeah, I think a lot of people don't know about that because a lot of people have their cocktail hours.
Right. And remember, you have to balance what you're trying to prevent. Patients will often say, well, I thought wine was good for heart disease. If I have my glass of red wine, that's going to reduce my risk of heart attack. And I say, well, again, it depends on the disease you're talking about. But the information on alcohol has stood the test of time. And so you do have an increased risk of breast cancer occurrence if you drink alcohol regularly.
Okay.
Prolonged, sustained intake of postmenopausal hormones, particularly if you take estrogen and progesterone, does increase your risk of breast cancer occurrence by a small amount, about 3% overall. So it comes down to a discussion of what are your symptoms and how long are you going to take postmenopausal hormones. That's why I couch that phrase in the terms of prolonged, uninterrupted use, because you have to balance treatment of menopausal symptoms against risk of breast cancer occurrence, and also bear in mind that you can be monitored mammographically.
Yes.
For development of breast cancer. Regular exercise at one point was thought to reduce the risk of breast cancer, and there are very good studies out there that suggest that that is the case. For a while, a low-fat diet was thought to reduce the risk of breast cancer occurrence, but the last study, the Women's Health Study, did not seem to bear that out. So I tell patients, realistically, I'm not sure that a low-fat diet does a lot for your breast cancer, but in general terms, it's good for you. And so what I famously tell patients is do what your mom says. Eat your fruits and vegetables and everything in moderation.
And take the cod liver oil. The fish, omega-3 fish oils, right? Remember that when you were a kid? Did you ever get that little spoonful in your mouth?
I do, yes, and I prefer the capsules myself.
I know the cod liver oil.
One last point also, being overweight. There is clear evidence that women who have an optimal body weight have a lower risk of relapse of their breast cancer. We're not quite sure why, but if you are close to your ideal body weight, you seem to have a improved prognosis.
What about medications to prevent breast cancer?
There's very good data on medications to prevent breast cancer. The oldest of these is a drug called tamoxifen. Tamoxifen has been around now for over 4 decades. But there have been several studies which have shown that tamoxifen reduces your risk of breast cancer occurring by about 1/3. Now, tamoxifen is not for everyone. You have to choose your patients at risk. Similar to the lung cancer screening data, It's not a drug you should apply to everyone. But if you meet the criteria for tamoxifen, and there are actually computerized models that you can use to predict your risk of breast cancer occurrence.
The Gale model?
Gale model. Then you can calculate that risk and in that context decide whether taking tamoxifen is right for you or not. Tamoxifen certainly has potential side effects. It does have an increased risk of stroke. That risk is small. It does have an increased risk of uterine cancer, again, small. And so what I do with patients is we look at their family history, we calculate their individual risk, we do the math. We see what's your risk of breast cancer, how much bang for your buck then do you get from taking tamoxifen in terms of reducing that risk, and what are the side effects, what are the potential problems you could run into, and then you make a rational decision on whether it's something you wish to take or not. There are additional drugs. There's a drug called Evista, which is used for osteoporosis, which has also been shown to reduce your risk of breast cancer occurrence. And more recently, there are a couple of drugs that we use for invasive breast cancer or for patients who have breast cancer, which when used in postmenopausal women have been shown to reduce their risk of breast cancer occurrence. And those newer drugs are two drugs called Arimidex and another called Aromacin, both in widespread use for early stage breast cancer.
Early stage.
But now having data to show that they can prevent breast cancer occurrence in appropriately selected high-risk women.
That's really wonderful to know. I have a lot of patients who ask me, they tell me, my mother had breast cancer, my grandmother had breast cancer, my great, it goes down the line, my aunt. The breast cancer was diagnosed at a very early age. When should I start screening?
Typically, I tell patients 10 years before the youngest member of your family. But talking about breast cancer in a young age brings up the whole question of genetic testing for breast cancer. And so that was brought to the fore by, I'll call it the Angelina Jolie gene. But really...
Yeah, no, it's true. When there's a celebrity,
right.
It's like that's the only disease that exists on Earth.
Right.
But, there is good and bad. At least it brings it to the forefront.
It brings it to the fore and it gets us discussing it, and that's important.
BRCA
And we're
gene.
talking about the BRCA1 and BRCA2 genes, which are not the only genes that cause breast cancer, and that's a common misconception. Patients will ask me for the breast cancer gene. Well, there are probably many, many different genes that help to increase your risk for breast cancer, but this is one that we can test for. And so, of course, a test that you have or a condition for which you have a test is a condition that you can then monitor for and try and identify patients. And BRCA1 and BRCA2 are genes that increase your risk of not only breast cancer, but also ovarian cancer and other minor cancers. BRCA2, for example, is associated with prostate cancer. And there are slight increased risk of upper GI cancers with BRCA1 genes. So if
pancreatic, right?
If you have a patient who presents with an appropriate family history, then one would want to test for that. And what I mean by an appropriate family history is you have to look for the flags that they might have a genetic condition, and that's usually early stage breast cancer. There's a particular type of breast cancer that we see associated with the BRCA1 gene, which is what we call triple negative breast cancer. It's hormone negative and HER2 negative. So if you have a young patient with a triple negative breast cancer, they should be tested. Family history is also tremendously important here. Knowing whether relatives on either side of the family had breast or ovarian cancer.
I've gotten a cold.
And I want to emphasize it's not just maternal transmission. Sometimes patients will say, well, it was on my dad's side. Well, this gene can be transmitted by either father or mother, and men are also at risk. It is very important to know. It's also important to know that male breast cancer is a described condition, and patients with male breast cancer are one of the groups who should be tested for BRCA1 and BRCA2.
That's very important to know. Now, again, there is a cost to this disease, and most insurances do not cover it.
Actually,
or do they?
They do once the guidelines are met. So for the average patient who, has watched Entertainment Tonight and comes into the office and goes, well, I want the Angelina Jolie test. No, we're not going to cover that. But if you meet criteria, if you meet appropriate screening criteria, most insurers will cover the test. There are some who still do not. And that's frustrating because you want to be able to identify the gene. The test itself is either a blood test or a little swab on the inside part of your cheek. So it's not a difficult test to do. It is expensive.
Like $3,000?
It's about $3,000. But the good news is that the company or maybe not so good for the company, but the test, they had wanted to keep their patent on it. And it went to court, I think, in 2013. And now a generic form of the test, if you would, can be developed. So other companies can start working on developing the testing. And as with all things with competition, one would anticipate the price is going to come down.
I know, because the Angelina Jolie decided that she had her breasts removed.
Right. And that's one of the interventions you can use. With BRCA1 and BRCA2, your risk of developing breast cancer is anywhere between 40 to 70%, depending on who you read and which gene you have. And that's a pretty high number. So many women will choose to have both breasts removed. Having said that, you can choose other things.
The medicines.
It's all about being informed.
Right.
If you are BRCA1 or BRCA2 positive, a screening MRI is more appropriate than a screening mammogram. And one can take the pills that we talked about, tamoxifen, to reduce your risk of breast cancer occurrence. So I have a patient in my practice whose sister died of breast cancer, her twin sister, in her 30s. And she has elected not to have mastectomies, but has been on tamoxifen in close follow-up with MRIs and mammograms. And so that's a viable option for women who choose not to have surgery. Similarly, you could choose to remove your ovaries, or you can choose to be monitored. Because the ovaries are so difficult to monitor, there is no good screening test. I am a big proponent of removing your ovaries once, in this setting, obviously not in every woman, but in a woman who's BRCA1, BRCA2 positive, of removing your ovaries once you've reached menopause. I think that's an important thing to do. Ovarian cancer, while uncommon, can be very lethal.
Do you have any of the latest? What's the latest? Oh, here we have.
I found a guy walking around the hallway. Betsy.
Okay. Well, welcome, Dr. Katzen.
Hi.
How are you today?
Good.
As you see, we have our guest, Dr. Brownie.
Yes.
And my mother already called, so that was great.
Yeah. Oh, you guys have been conducting a great program. I've been listening.
It is.
Thank you.
Thank you so much. And to ask you again about the, you said screening MRIs are the better one for?
For certain women. The current recommendations are if you have a lifetime risk of breast cancer, and again, we can calculate that, we can estimate that, of 25% or more, then an MRI is a preferred screening test. So mammograms are appropriate for the woman at average risk, but for women who are at heightened risk, either from their genetic makeup or their family history, or certain other medical conditions, an MRI is a preferred screening test if your lifetime risk of breast cancer is estimated to be 25% or higher.
That's pretty high. Dr. Brownie's here, our guest, and now we have Dr. Katzen from Southwest Florida Regional Imaging Center. I know the time has gone so quick. I was going to ask you, that clock is not correct. But anyways, one more question about you talked about ovarian. What's the latest with ovarian? No screening test yet.
No good screening test yet.
I know.
The serum CA-125 is really not an adequate screening, but, and this is one of the things I love about oncology, there's always new data. They are now trying to develop, if you would, a super sensitive CA-125. And so my prediction, we'll see how good I am, is that sometime in the next 5 to 7 years, we will get an appropriate blood screening test for ovarian cancer.
Oh, that would be so good.
That'd be great.
That'd be really, because I know a lot of people ask me, and I also keep up on the data, and there's nothing really out there.
Not yet,
not
but I
yet.
hope to change that answer. I hope
Great.
we'll change that answer.
Well, you're going to have to come back on the show.
It'd be a pleasure.
It's been great. We're really lucky to have you here. So I know that you were talking about the single breath CAT scan. Dr. Katzen, we talked about lung cancer screening. Could you tell us about that single breath CAT scan? I think that's important.
Yes, we talked about that before.
Yes.
And people who have a high risk for lung cancer, people with advanced COPD who have large hilar nodes or whatever, we do that. And even a 16-slice scanner can do a scan in one breath. And it's a useful test. I saw an article recently where somebody complained that we were finding too many cancers now. That's a very interesting political.
Yeah, there
point of
was.
view,
I
isn't it?
saw that article too. What's your take on that, Dr. Brownie?
Well, I think it comes back to, are we going to do any harm with a screening test? You will find a lot of what I call dots and blots, spots on the lungs, that may not be cancer. And so certainly you may end up doing a lot of negative biopsies. But that's why you talk about picking your population to screen. It's kind of like going fishing. You go where the fish are. So in somebody who is a smoker and who has put themselves at higher risk of lung cancer,
Right.
by virtue of that behavior, that's the group you want to look in. And therefore, you reduce your chances of doing harm, and you heighten your chances of actually catching a lung cancer, of finding a fish.
I think that's a great analogy. Go where the fish are. I am finding that with our obesity epidemic in this country, and also a condition called metabolic syndrome, where women have insulin resistance and men, elevated triglycerides, low HDL, high blood pressure, an increase in endometrial. Talk to us about that.
Unfortunately, no good screening tests for endometrial cancer. Also, although I would emphasize postmenopausal bleeding is not normal. I will often see women who said, well, I kind of watched it, and when it didn't go away, 6 months later is when I went to my gynecologist. It is never normal to have postmenopausal bleeding. So if you see that, you need to make an appointment with your gynecologist or your primary care as soon as possible. Again, early detection is key. Cure rates directly correlated to stage. The earlier you find your cancer, the better your chances of cure.
And I totally agree. And like you said, look at what is your risk, and look outside the box and see what is your family history, your risk. People think, like you said, I want that test that you'll see. I want the Angelina Jolie test. But it really comes down to a full physical, a full history, exam, everything, before you decide what's the test that's appropriate.
Correct. And family history is so critical to helping to decide what to screen for. Family history and lifestyle behaviors.
Lifestyle, exactly. And it's not just let me get that test for that disease. You have to make sure it's appropriate. I think that there is a lot that's happening in your field, and I see that you participate also in clinical trials.
Yes, Florida Cancer Specialists has a very active clinical trials program because most of the progress in oncology comes from clinical trials. We'll never know if new treatments are good until we test them out. And so our clinical trials program is available in our Port Charlotte office, and in some cases we have additional trials available in Sarasota or Fort Myers. We also are Moffitt affiliates, so trials are available through that affiliation also.
Oh, really? That's great. And you also have an office in Northport?
We do. We have a smaller satellite office in Northport for the needs of our patients there in that community.
That's really great. That's really wonderful. I know you have your place. And give us, if anybody wants to call, give us your phone number.
Sure. The office number is 941-766-7222, and that will take you to our Port Charlotte office.
That's really great to know. That's really great to know. Are you finding that, are most of your patients then referred by other, or do you just have people say, I'm worried about cancer. Can you please help me with this?
No, it's a referral practice. You usually have to have an established diagnosis of cancer to be referred, or on occasion, a physician or a primary care will say, I'm worried about this patient, they're losing weight. Could you please see them and see if we're missing a cancer or some other problem. But generally speaking, you are an established cancer patient by the time you come to our door, or an established blood problem. Because as we said, we do both blood and cancer.
I'm finding so many people have iron deficiency anemia. Could you talk to us real quick about? I know we only have a few minutes to go. Boy, time has just flown.
Iron deficiency anemia, very common. The analogy I give to patients: iron is a building block of red cells. If you don't have it, you can't make blood. And so anemia just describes that your blood count is low, but there are many, many different causes. With iron deficiency, it could be that you're just failing to absorb iron. But there's a concept in medicine I like to talk about called the things you can't afford to miss. And the thing you can't afford to miss in iron deficiency anemia is whether you have a bleeding cancer.
Right.
And so any patient who I see with iron deficiency anemia needs to be up to date on their colonoscopy screening. And we need to make sure that they don't have a bleeding lesion, cancerous or otherwise, in their gut.
Mm-hmm.
So once we have established that, then you can replace that iron, either by pill form or by IV, and then monitor the patient. But the take-home message for anemia is not all anemias are iron deficiency. I will often see patients referred with anemia who were given iron without us really figuring out if a low iron was the cause.
And that's the one thing I always tell patients. We have to know the root cause. What is the root cause that you have plaque in your arteries? What is the root cause that you have anemia? You know, people say, well, can I go take iron pills? I go, we don't know what's causing it.
Exactly. Iron pills won't work unless it's iron deficiency.
Right. And if you're not absorbing it, you're going to take a pill by your mouth, then that's another story. I mean, everything has to have a reason.
Correct.
And I think that's really important. I know we're about to finish the show, and we're so lucky to have you today, Dr. Brownie. Dr. Katzen, do you want to say anything?
No, I'm enjoying listening to you ladies.
Well, it was great. It was a pleasure. I'm glad you asked me, and I had a great time. I hope we've provided some useful information.
Oh, I know you have. And your orchids, are they doing okay?
They're doing wonderfully. Thank you.
We both love orchids. We have a passion for them. They're so gorgeous. I love any kind of plants. We're really lucky to have you today. I want to thank Dr. Vance Brownie from from Florida Cancer. I'm thinking we live in South Florida. We live in Southwest Florida, Punta Gorda, Port Charlotte. Florida Cancer Specialist, thank you so much. Thank you, Dr. Katzen, for being here. And remember, everyone, this is the Slippery Slope of Lipids. Thank you for listening. Thank you to our guest. It's been great, and stay healthy.